Good afternoon, everyone. My name is Janice Whitaker. It's my pleasure to serve as the CGNE Administrator and Education Program Manager. I also host the CGNE Seminar Series, so thank you for attending with us today. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing, in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care Pennsylvania. Today's seminar, Ageism, Uncovering the Invisible Ism, will be presented by Dr. Timothy Farrell, Professor of Medicine, Interim Geriatrics Division Chief, and Associate Chief for Age-Friendly Care at the School of Medicine at the University of Utah. He's also a member of the American Geriatrics Society Ethics Committee. Before we learn more about Dr. Farrell and his work, we do have some disclosures and announcements. Penn State Ross and Carol Neese College of Nursing is approved as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Participants with a valid RN license who attend the entire Nursing Continuing Professional Development Program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. Just to make you aware, this seminar is being recorded. If you have any comments or questions for our speaker, please enter them into the chat feature. You can also raise your hand, and Jenny Rank will kindly unmute you and offer you the opportunity to speak aloud. We also will be putting the post-event evaluation survey link. It will pop up in your browser at the end of the webinar, and it will also be emailed to you within 24 hours. This is required for RNs seeking contact hours, but we do ask that all attendees complete the evaluation to assist with our data collection. Again, RNs will need to complete the evaluation, but we do also track Zoom in and out times as part of attendance records. And if you do meet the requirements, nursing continuing professional development certificates are emailed to the RNs within a month of the seminar. And if you have any questions about any of this information or anything else, please feel free to reach out to us at cgne@psu.edu. And now it's my pleasure to introduce Nawal Alasari, one of our CGNE graduate student affiliates. Nawal is in her 2nd year of her PhD program, and she's interested in studying cognitive reserve and aging in relation to the social determinants of health, I just learned. So we're thankful that Nawal has sought opportunities to engage with our center, and that she's here today to introduce Dr. Farrell.
Thank you, Jenny. Good afternoon, everyone. Dr. Timothy Farrell is a professor of medicine and interim geriatric division chief at Sponsor Fox Eccles School of Medicine at University of Utah. He also served as a geriatric division associate chief for age-friendly care and as a physician investigator at AV Salt Lake City Geriatric Research, Education, and Clinical Center. Dr. Farrell completed his AB in philosophy from Dartmouth College and received his MD from University of Massachusetts Medical College, followed by family medicine residency and geriatric medicine fellowship training at Brown University. He is a prior recipient of HRSA Geriatric Academic Career Award, and was a 2016-17 TED Schools Emerging Leader in Aging Scholar. Dr. Farrell serves as a chair of AGS ethics committees and has an expertise on underrepresented older adult resource allocation strategy and ageism. So, Dr. Farrell, the spot is now yours.
Thank you so much, Nawal and Janice, for your, first of all, welcoming me to present and inviting me and your kind introductions. Let me just share my screen and we'll get started. Jenny, are we in good shape with the slides? The
Looks
audio's
great.
good? Fantastic. Well, also just want to say before we get started, I'm so pleased to be here, and I've had really wonderful collaborations with nursing colleagues in my career, specifically the University of Utah College of Nursing. And so to engage with you at Penn State is just really a wonderful opportunity. And I feel like our universities are aligned in several ways, including our mutual interest in age-friendly health systems. We are an age-friendly university. I understand Penn State is on that trajectory as well. And so I think there's just lots of overlaps, and I'm just thrilled to be here. All right, so we're going to talk about ageism, uncovering the invisible ism. I actually thought about not including the word ageism in the slide title to sort of make light of the invisibility, but I thought, well, we have to know what the topic is about, so I left ageism in there. And let's see if I can advance. There we go. I have no relevant conflicts of interest. So I want to start with sort of an unusual slide. I'm going to talk a little bit about an elephant in the room, which is sort of this current election cycle. And I will try very hard not to be political in any way, but ageism really dominated the headlines for probably a good 2 or 3 months during the summer, and continues to pop in the headlines. But this posed a little bit of a challenge for me because when the campaign changed drastically in July, it sort of changed the case I was going to present. But here's the case I was going to start off with, which I think is still quite timely. And we have 2 people, I'll call them JB and DT. I have withheld their names to preserve anonymity. They're competing for a position of great responsibility. JB is 81 and DT is 78. And the question I was going to pose is, how should we think about age in this context? And it's a little bit humorous. Of course, we all know who I'm talking about with the presidential campaign. Obviously, things change. Now we have only one candidate who's older. Yet I think many of the things I'll talk about today still apply. And so I was just sort of looking through the, sort of the news media to kind of see what was popping up in terms of the election. And some of the headlines are sort of benign, but some get a little bit ageist. So we've got NPR saying, is there a double standard on age between Trump and Biden? Politico saying, the battle over who's too old, too forgetful, or too confused. And my favorite one from USA Today is Biden and Trump are older than color TVs and hula hoops. So we'll talk a little bit more about the media, but it's not hard to find examples of content that's a little bit objectionable. So Dr. Laura Mosqueda, who's a geriatrician currently at the University of Southern California, has said, ageism is the only ism in which we act against our future selves. And so it's an interesting way to think about this concept, because unlike other isms, this one is pretty much universal for anyone who's fortunate to live to older age. Another sort of saying that I've picked up over the years that I like is sort of ageism, everybody's doing it, right? So everyone's aging, and it's only really a matter of time, unfortunately, until folks confront the negative effects of ageism. So I'd like to start with definitions, and one is that ageism is discriminating against a person solely on the basis of age. It can be ageism against younger people. That's sometimes called youngism. I won't really go into that in this presentation. I'll be talking about older adults, but just to say that it can work in other directions. People assuming that younger people lack capabilities or might not be experienced enough to handle a task, for example. The reason why I'm showing this slide from Dr. Robert Butler, he's a luminary in geriatric medicine. I believe started the first geriatric medicine fellowship program in New York City. Wrote a book called Why Survive Being Old in America back in the 1970s and won the Pulitzer Prize. This is where ageism as a term was first coined. So he's credited with coming up with this term. Of course, ageism has been around forever, but just in terms of terminology, that's sort of where it all started. And I really like this framework from the World Health Organization that talks about 3 dimensions of ageism. I think this framework can also be applied to other isms, but it's particularly useful for ageism. And you'll notice that there are sort of 3 dimensions here. Stereotypes, how we think about ageism, prejudice, or how we feel about ageism, and discrimination, which is how we act in terms of age. And there's also this positive and negative valence, if you will. The next few slides, I'll show you kind of what the WHO means by this. So if we take aging stereotypes in health, one way to look at this is sort of a positive and negative valence for younger people and older people. So if you look at the top left, you'll see that younger people are often thought to be healthy, physically active, strong, and energetic. If you go down to the bottom right, you'll see that some stereotypes of older people are basically exactly opposite, frail and weak, needy, disabled, etc. What's very interesting here, though, as well, is that if you look at the top right box and you see the positive valence for older people, that they're warm and likable. I will say in my travels as a geriatrician, I've met plenty of grumpy older people. So even the positive stereotypes often turn out to be inaccurate. So my point here is that it can kind of work in both ways. Yes, we have negative stereotypes, but we also have positive stereotypes, and they may or may not be accurate. And that speaks to sort of the heterogeneity of older people and sort of the need to treat each person individually and recognize sort of their individual attributes. This also works in terms of like the workplace. We certainly have more and more older adults in the workplace. In fact, our 2 examples of DT and JB in the introductory slide are, they're out there in the world working. And so we have, again, the same types of dichotomy, positive and negative. Younger people are often stereotyped as being energetic, ambitious, tech savvy, and hardworking. The tech savvy one, I think, is really important. So you look at the bottom right, the very bottom, under older people as not being technologically competent. Later this afternoon, I'm actually working out of state today. I will be logging on to a virtual platform to talk with older adults, and we're doing it by Zoom. And my patients generally are able to do that. Sometimes they need some help, but that not technologically competent one is sort of a persistent stereotype of older people. And I certainly have plenty of patients engaged with patient portals and the like. So that one is particularly pernicious, I think. And then the media, of course. So we've got a stereotype of younger people being attractive, and then down the bottom right, older adults, unattractive, unhappy, senile, badly dressed, sort of unkempt. That stereotype certainly is also quite harmful. So I think the WHO has a great framework. If you look at their global report on ageism, just Google that term, you'll find a quite comprehensive treatment of ageism that goes through the definitions and goes through implications as well. So there are thought to be 3 types of ageism. I've talked about sort of the dimensions of ageism, but in terms of actually how this plays out, there's sort of the interpersonal ageism, which is sort of like, when a patient comes in and someone says, hi, sweetie, or hi, honey, instead of, how would you prefer to be addressed? Or saying, Mr. or Mrs. Jones. And that's sort of a very obvious form of ageism. Where it gets to be a little more invisible but still quite apparent is with institutional ageism. So those are policies or approaches that might blatantly call out sort of say a resource that older adult cannot have. And I'll get to that in a little bit when it comes to rationing. They may do that, or they may just simply not consider older adults. And I'll give you an example of that. We were at our clinic at the University of Utah. We were going over some metrics with our call center. So the people in our outpatient clinic who contact our patients, and we were getting this notification that a large percentage of our referrals to specialty providers were not being acted upon. They're basically just expiring and closing. And we come to talk to the call center and we ask, well, how are you contacting our older adults? And it turned out that many times when they were calling a patient to say, hey, your appointment with gastroenterology is coming up, don't forget to make the appointment, they would call but hang up after only a few rings. And from an age-friendly perspective, that doesn't really give an older adult with maybe who has limited mobility time to get to the phone. Perhaps they could let the phone ring a little bit longer or call back. That's a very subtle example of ageism where I don't think anybody is malintentioned necessarily, but nonetheless, it's not considering broadly the heterogeneity of older people. Some older adults may be quite spry, get up and answer the phone right away. Others may need more time. So once we made that change, turns out the percentage of consults that were actually referrals that were actually completed increased. So there's really direct clinical harm that can result from ageism. In this case, it'd be decreased access to healthcare or delaying in receiving healthcare. And then the third type of ageism is called internalized or sometimes self-directed ageism. And that's where because a patient may have experienced lots of these other forms of ageism over their lifetime, they sort of start to think, gosh, I'm older, so I therefore must be incapable of doing certain things. And it's been shown that when folks have a negative self-perception of aging, it just sort of makes things worse. And there's like more ageism that happens when they interact with our healthcare system. So it's sort of like you accumulate this burden of ageism. And then once you sort of interact with the health system, it just kind of gets worse because of those prior exposures. So the WHO sort of points this out. There's lots of intersecting arrows in this diagram, but basically they say that these three types of ageism are intertwined and mutually reinforcing. So you can see, if you encountered the health system and someone called you sweetie instead of Mrs. Jones, that may lead to just worsening that self-directed ageism. So recently I took a little trip through Amazon and also through our local party store we have here. And I came across a lot of ageism. So this one on the left, bumper stickers for seniors, this is a greeting card that I found you can order online. And look at some of the things here. If you don't like my driving, tell it to somebody who can hear. I completely forgot where I'm going. My other car is a motorized scooter. So from an age-friendly perspective, there's lots of tropes here that are really playing on the M's. So there's a sort of a stereotype about mobility here, that if you're older, you of course would need to have a scooter. If you're older, of course, you develop a sensory deficit. And so really, it's just amazing when you go look at a greeting card. Like I can't look at greeting cards the same way after sort of, familiarizing myself with ageism, because the cards are quite ageist, and I understand that there's sort of a certain humor associated, but it really does play on a stereotype. Most older adults do not need hearing aids or scooters. So some do, but many don't. Here you have on the right-hand side, someone turns maybe 65, they get a barricade that says, caution, slow senior old zone. Now look there, there's a picture of someone slipping and falling, again, suggesting that mobility problems are an inevitable part of aging. And while, of course, older adults can have mobility problems, oftentimes they can be remedied or mitigated. Here's just a few more. We have our sort of kit that you can put on top of a birthday cake. And again, says slow down, old folks zone, right? So again, a mobility stereotype, and also a stereotype about driving, uh, suggesting that older adults may have difficulty with driving. Many do, but I'll give you an example from my own life. My dad was flying corporate jets until age 78 and only stopped because of COVID. So it's all about heterogeneity. Over on the right-hand side, you have your old man walker, complete with, I think there's old man hearing aids. Again, there's that sensory deficit and mobility trope that's playing on. And so really the reason why this is inaccurate is borne out by studies. We know that only about 2.5% of people over age 65 live in long-term care like nursing homes. But this kind of blew me away. I sort of think of microaggressions as sort of an issue among millennials or Gen Z. But if you look here, a study has shown that almost all people experience microaggressions about their age. And this starts quite early. It actually starts at age 50 before we consider people to be older adults. So the flip side of this is I think there's an opportunity to reduce the impact of ageism before age 65. There are things we can do upstream to hopefully, at least in healthcare in our sector, make this less of a problem. I really think because, I show the WHO slides about the work domain and other domains. There's other sectors like entertainment, politics, et cetera. There's a lot of work to be done, and it's sort of overwhelming to think about how you sort of turn the tide here. But I think if we look inward, think about what we can do in healthcare, then hopefully we can be an example for other sectors of society and improve things that way. So ageism is definitely hiding in plain sight. The WHO actually goes out on a limb and says they think half the world's population is thought to be ageist. I'm not sure how they came up with that number, but I would say, if anything, it may be an underestimate. And I think it's probably, again, that people are well-intentioned, but they often don't think about it. And so then it doesn't get opposed. It's so rampant in all sectors of society that it is invisible, in my view. And here's another thing that I've noticed locally. There are lots of sort of, DEI type of activities out there. Ageism is often not included. And again, I don't think that's intentional. I think that's an oversight, but that's an opportunity for all of us to think about including ageism in, media campaigns, internal messaging in our institutions, right? Ways to oppose ageism that maybe have not been realized before. And, this isn't just an academic issue. There are real adverse effects of ageism. I talked about the access issues in our clinic, but there's also reduced life expectancy, up to 7.5 years among those who have less positive perceptions of aging. So it really is quite damaging. Reduced quality of life. Those of you who follow the social isolation loneliness literature, one of the main contributors to that literature is just down the road in Utah at BYU. They've shown that being isolated and lonely is the equivalent of smoking, cigarettes in terms of its damaging effect. So if ageism increases social isolation and loneliness, that's definitely not a good thing. Increased risk of elder abuse. And that makes sense to me, right? Because if older adults are perceived as having less value, then I can understand it's not ever acceptable, of course, but you can see how that would lead to increased elder abuse, whether that's physical abuse or neglect, financial abuse, etc. And this is expensive, right? So ageism actually has a cost, and that's probably due to missed opportunities to intervene on common illnesses. So the 8 most expensive illnesses included things like COPD, things that we see every day in our clinics. There are other ways too that ageism manifests in healthcare. A very important one is exclusion of older people from clinical trials. So that makes life very hard for me as a geriatrician, because I end up having to often extrapolate from clinical trials that involve, much younger, healthier people, and people that have, even if they're older, they may have only one or two comorbidities. And, my patients all have, 5, 6, 7 or more comorbidities, and they have multiple medications. So it really makes it difficult to counsel patients appropriately about their options when the clinical trials for treatments I'm offering don't include them. I will say that the American Geriatric Society has been working very hard, along with, I think, groups like NIA, to make this really a requirement to have older people in clinical trials. But for a long time, this has been a very, very difficult problem. I'll add to this, and again, I think this is unintentional. We have a lot of good people in medicine and nursing, pharmacy, et cetera. But, just to speak to residency training, we only have, to my knowledge, 3 different programs, which are all primary care programs: family medicine, internal medicine, and med peds, that require geriatrics rotation. And so it's been shown, that you can't just like expose trainees to older people by happenstance and expect them to come out knowing about the 4Ms and knowing about ageism and geriatric models of care. You really have to have an intentional educational experience for them to sort of internalize those competencies. And then we have the unjust resource allocation strategies during COVID, and I'm going to talk about those right now. So this headline to me was breathtaking when this came out. There was a lieutenant governor in Texas who said that he and other seniors should be willing to die to get the economy going again. So sort of this like generational battle, where one generation sort of is sacrificed for another. So let's talk a little more about ageism during COVID. So dating back to H1N1 flu, and maybe even before, states have had resource allocation sort of crisis standards of care, very well intentioned, that decide, how to ration scarce resources like ventilators, for example. And we started to see during COVID that states were sort of dusting off these protocols from the H1N1 era and applying them to COVID. To my knowledge, thankfully, none of the resource allocation strategies were actually implemented, although I believe it was Arizona that did sort of activate, if you will, their standards. But to my knowledge, they weren't used. However, just the fact that these standards exist and were very nearly used, I think means they really do warrant scrutiny. And many of the standards, crisis standards of care, had what are called age-based cutoffs. So I'll use my own state as an example. So I live in Utah, and there was a standard that if you're 90 years or older, you sort of went to the back of the line. We actually ended up having a very nice conversation, very professional outreach to our local crisis standards of care committee, and they ended up removing the provision, which was great. At the federal level, there was action. I think it was in the Department of Health and Human Services or Department of Justice, I can't remember which one, but there's a federal office that was looking into this, and they actually called out Utah and other states, but they also commended Utah and other states for removing these provisions from their crisis standards. And if you have an age-based cutoff, it leads to persistent beliefs that older adults' lives are just less valuable. It just makes the whole ageism problem worse. Probably the only thing that's worse than having an age-based cutoff or a crisis standard is having no approach and just sort of leaving it to the clinicians in the field. That just leads to even more inequity because you have folks making really difficult ethical decisions at the same time that they're supposed to be making clinical decisions. And so we don't really want to do that. Like the whole point of having a resource allocation strategy is that's been thought through, that there are protocols, that there are checks and balances, if you will, and it's not just falling on the shoulders of a nurse or physician. And so, again, that's why it's so important to look at these standards with sort of a fine-tooth comb, make sure they're updated going forward. So I've been fortunate to be part of the ethics committee at the American Geriatric Society, and I remember very well around 2020, reading these headlines about initially in Italy, where there seemed to be rationing that was based solely on the basis of age, and it really got me pretty upset, but also fired up to make sure we do whatever we can to not have that situation here. So I took advantage of some of that time, in lockdown, if you will, um, virtually to research this and assist the AGS with coming up with a position statement. And so I just want to share with you some of the most important recommendations from that position statement. The first one is that age per se should not be used as a categorical exclusion from therapeutic interventions that represent the standard of care. So it's okay to use age as one factor among others, but age alone ethically is not defensible because of the heterogeneity of older people. So, I see very often in my practice that I have very robust 85-year-olds who probably have a longer life expectancy than some very, very ill or 50-year-olds with chronic conditions. So it's really hard to say that the 85-year-old should not receive a resource. There should not be specific age-based cutoffs in resource allocation strategies, and functional trajectory, multimorbidity, and frailty are better predictors of mortality than age alone. So you get into things like Apache scores and all kinds of mortality predictors, but they, very appropriately tend to have more than one variable. If you just isolate age, you're going to probably get it wrong more often than not. Okay. I've alluded to this a little bit earlier about age-friendly health systems and the 4Ms, and I just want to make sure that we are all sort of on the same page about this, because the what matters part of the 4Ms is really critical in understanding why ageism is so pernicious and harmful, because ageism basically makes it very difficult to impossible to get at what matters. What matters is the North Star of age-friendly health systems. So all the other M's are sort of aligned with making sure an older adult can do what matters most to them. That's why I really like why the Hartford Foundation, Johnny Hartford, IHI put what matters as sort of the north position on this, what I consider to be like a compass rose, because what matters is so important. But just for those who may be unfamiliar with the framework, eliciting what matters is really aligning their health outcome goals and care preferences across different locations of care. Mobility is making sure an older adult can move every day to do what matters most to them. Medications, making sure we're not, causing side effects that make it harder to do what matters. And mentation is looking at dementia, depression, delirium, and addressing those again so people can, have a high quality of life and do what matters most. So what matters most is foundational, in my view, when it comes to how it relates to ageism. Okay, this figure is a little bit complicated, but I do want to walk through it because it kind of explains, kind of ties together some of the concepts we've talked about with ageism and how it relates to what matters. So if you start at the top left with sort of our society's approaches to aging, the negative messaging we get in all different sectors, entertainment, media, politics, and healthcare, that sort of results in ageism. If you follow this through, then someone gets sort of a negative self-perception of aging. And then when they interact with a clinician, if they have that negative interaction, the clinician sort of ignores them or uses a disparaging term, the patient may perceive ageism. And then if that happens, my sense of this is that the patient's going to clam up and they're not going to be willing to share what matters most with them. Even worse is if you have other isms, such as racism, that sort of combine, then it's not surprising that we see these poor outcomes, poor communication, decreased adherence to medications, increased cost, and with the not just with crisis standards, but in usual care, maybe deprioritizing a resource that really should go to an older adult but doesn't get to them. So it's really important to kind of recognize the contributors to ageism and try to interrupt these pathways wherever we can. So what are some ways that ageism is a barrier to eliciting what matters, that center part of that last diagram? So I kind of divide this into acts of commission and acts of omission. The acts of commission, this is that interpersonal ageism, would include, calling somebody sweetie or honey instead of Mr. or Mrs. Acts of omission, and I see this all the time. I'll be the first to admit that I've been guilty of this, and I really have to stop myself from doing this. Would be, an older adult comes in with their care partner. It might be a family member. It might be someone from the assisted living who's coming along with them. And maybe the older adult has cognitive impairment. It's very tempting to address all the questions to the younger care partner and just sort of completely ignore the older adult. What I've started to do in my practice is to first start off by addressing the older adult and asking them questions. Now, they may not be able to give me much back if they have cognitive impairment, but I think it's really important to sort of start with them because after all, they're the ones who are there for the appointment. And then I'll say, I will be asking some questions of your care partner, and also I ask, I invite them to interject and make sure their preferences are known. When I'm talking to the younger care partner, I try to include the older adult in the conversation, and then when we wrap up, I start with the older adult. I do a teach back if that's possible, depending on the degree of cognitive impairment, to really ensure that I'm not missing the what matters piece. Now, of course, the younger care partner may be the source of the what matters, but I think it's important to include the older adult. By the way, parenthetically, another place where care partners become important are in patient portals. And so they may be responding on behalf of an older adult. Sometimes they use the same login, sometimes they don't. But that's another place where it's important to ensure that we're not just getting the care partner's view, but we're asking them to sort of ask on behalf of what the older adult wants based on the preferences they've expressed over the years. But the end result is if there are these acts of commission and or acts of omission, that the older adults' values and goals and preferences can get minimized or ignored, and then you don't get to what matters most, and then you're sort of lost because then you're not centering the care on their values. Some of you may have seen a chart that looks somewhat like this. If you go to the reframingaging.org website, which I really like, you'll find this. But I think this is just useful to have. We're actually soon to launch an internal campaign in our health system that has to do with reframing aging. And so it's sort of like say this instead. So in general, try to avoid terms like elderly or senior citizen, which sort of have negative connotations for many, and replace with older person or older adult. One thing I saw a lot of when I was sort of beginning my geriatrics training back in around 2007 or 8 or so, I saw a lot of references to the silver tsunami. And I don't think it was intentioned this way, but it sort of invokes this image of like this overwhelming number of older people crashing on our shores and just sort of like swamping out everything else. So it's really kind of a negative that sort of suggests that, oh my gosh, the older people are coming. What are we going to do? We don't have enough resources. A more positive framing is to say, with people living longer, this presents more opportunities to, leverage their experience, their wisdom, their expertise. Back to the media report about the lieutenant governor talking about intergenerational conflict. Oftentimes there's the sense that, we should be fighting aging or battling or struggling. But a more positive framing, again, is accumulation of wisdom, insight, and experiences. And then, conflict between generations. Again, that media example I showed. A better way to frame this would be in a just society, we treat all people equally so that there's not that intergenerational conflict. Earlier, I alluded to the really negative ramification of having another ism involved besides ageism. And certainly, our patients come from all different backgrounds. I was fortunate to be involved with a paper that the American Geriatric Society put forth a few years ago, in which we considered the implications for racially and ethnically minoritized older people. So not only are they dealing with everything I talked about, the microaggressions and the interpersonal, institutional ageism, they're also dealing with racism and other isms, unfortunately, depending on their background. And there's evidence that this intersection leads to delayed and foregone care. So, for example, the hypertension that's not being addressed and then manifests as a stroke at an early age than it otherwise would have. I talked about exclusion from medical research. That's even worse when you consider, people from certain backgrounds not being included even before you get to their age. Worsening adverse health outcomes, including death and disability, and then worsening morbidity and mortality from COVID. So this intersection is really powerful and needs to be considered. So what can we do to oppose ageism? And I'll be wrapping up in a few slides and looking forward to your questions. We need to look and understand our own biases when it comes to ageism. So really looking inward first. And I think that's not only, everyone as a healthcare professional, but also looking inward as sort of a healthcare sector when it comes to ageism. And then advocating for a just healthcare system, treating everyone equally. There are different ways to advocate for this, and it probably varies based on local context. As Tip O'Neill famously said, all politics is local, but that advocacy is really, really important. Additional strategies include, as I mentioned earlier, not forgetting about ageism when opposing other isms and including that in those campaigns, including geriatric training in all health professions programs. And that's particularly important because Medicare is really the funder of these graduate, health professions programs. And so it makes sense. There probably should be some training for older adults, even pediatrics, right? There's grandparents bringing in their grandkids to appointments and understanding the intergenerational aspects of that. This last one here, really important, including geriatrics health professionals when formulating policies that affect older adults. That's probably a reason that there were these age-based cutoffs, because I would be willing to wager that when the crisis standards were formulated during the H1N1 era, there are probably few, if any, geriatrics health professionals at the table. And so now we're kind of having to undo some of these policies as a result. Other things that can be done, community outreach. So having positive messaging about aging starting at a young age, elementary school, middle school, high school. This is our future healthcare workforce. Asking what matters most to patients of all ages. So I have started asking what matters most to you, not solely what is the matter with you. Those are both important, but the what matters question is really huge. And it doesn't take that much more time, I've found, in a patient encounter. Including questions about ageism and patient experience surveys. So we have a survey that goes out to our entire health system. And in the next version, I'm going to be advocating to include a question that every one of the 20,000 University of Utah Health employees would receive about ageism and their experience with it. Including anti-ageist themes and marketing campaigns, making sure if we're going to advertise age-friendly health systems that we're doing it in a way that accounts for the heterogeneity of older people. I think this is my next to last slide, just to say that, bringing it back to the age-friendly ecosystem and environment, there are lots of ways that we can work, lots of sectors in which we can work just within healthcare to oppose ageism. So that includes not just healthcare systems, but going kind of around this pinwheel here, public health, workplaces, home and community-based services, home health, for example, area agencies on aging, cities, communities, and states. So we have a state master plan on aging. You may have the same in Pennsylvania. Education and research, again, recruitment and trials. So keeping this in mind throughout the breadth of where we encounter older adults, I think the ecosystem of older adults is really, really important to make sure anti-ageism work is considered in all of these places. So I think with that, and I'm not sure, Jenny, if I should just leave the slide up or not, but I'll be happy to take your questions. And I really thank you for your attention and the opportunity to be with you today. I'll turn it back to the team. Thanks so much.
So, oh my gosh, Dr. Farrell, that was amazing. Thank you so much for providing us a wealth of really great information, as well as so many things to consider and think about in relation to the 4Ms and the framework. I hadn't really thought about applying both kind of the positive aspects of the 4Ms as well as how ageism could impact the 4Ms. So that was a really interesting perspective to think about. And thank you for sharing some ideas related to strategies as well. So I do think you can stop sharing your screen if that's okay, and then we'll proceed with there's some wonderful comments in the chat about an outstanding evidence-based presentation, Donna Fick. She's saying thank you and love the discussion of how prevalent it is currently and what we can do to help. She also had made a comment earlier related to when you were presenting information about the impact of ageism during COVID and some of the barriers for older adults. She remarked that that was true for people living with disabilities as well, that there were some of those restrictive aspects to care and other things at that time. Jenny, I think there's a question in the Q&A, if we want to pull that up. So that says, do you find that individuals self-exclude from treatment, saying I'm too old, or it would reduce my already limited mobility, like, can't drive, that kind of thing? So
Yeah, thank you for that question. I do. I think there are patients in my experience who just don't feel that they're capable. And I think, Janice, to your earlier point, I didn't touch on this, but there's sort of this also, maybe intersection is the wrong word, but there's sort of this like sense that ableism, another ism, sort of is at play here. And so particularly older adults with issues with mobility, maybe very reticent to become involved with, say, an exercise program or something really basic. That also may be due to social isolation and not having not feeling like they could actually engage productively. So I think there's all kinds of internal feeling that probably is just reinforced, and then it's sort of a self-fulfilling prophecy, right? Because the less they do, the more deconditioned they may become, the less they can do, and the more concerned they are about their ability. And one more thing I would add to that is, I think some of the spaces in our community are not really age-friendly in the sense that, my patients are probably not very likely to go to a gym where the 25-year-olds hang out, right? And I think there's probably work that can be done to get them there. However, I do have some patients that do, and it's fine, but it takes kind of sometimes a special person to kind of break through that peer, cultural stereotype. Like, what is a 75-year-old doing at LA Fitness, right? So it works in a lot of interesting ways. And I think one of the things that I try to do with patients is just to have the what matters conversation and try to point out, actually you might be capable of doing some of these things, and here's how we can take some initial steps.
yeah, Yeah, as one of your slides, I think it was one of the graphics, the charts that talked about influences from entertainment, media, politics, and healthcare. And you just mentioned what I was gonna suggest adding to that list would be cultural.
Yeah.
I think that so many of the influences on my thoughts about aging, throughout my life were really cultural in nature, from other people that I interacted with and, certain views and biases that they might bring to a situation. Can you comment about that a little bit?
Sure. I mean, I feel like uh you know, I guess I'm taking care of a patient population that is fairly sort of suburban population. There's not a lot of cultural variety, if you will, where I'm currently located. But I feel like there might be cultural norms that are at play, and they may cross other boundaries that kind of extend beyond ageism. So it could be, you know, I have, older women who may have been very traditional households, and getting out and exercising is just something they never did for whatever reason, right? Is that cultural? Is it sort of their role in the family? Um, and so sometimes it does feel like it's a bit of an uphill battle to kind of ch almost challenge something that's been so natural for someone to be in that kind of role. Um, but it's not impossible. And I think that part of the challenge is also finding sometimes, okay, well, you're not comfortable with this approach, but is there something that aligns with your values that you'd be comfortable doing that might enable you to achieve what matters? And it may be a different way of achieving mobility that's not going to LA Fitness, but doing something that is at least they're willing to try.
Yeah, yeah, that's great. So Stephanie Cole, who works for the Department of Health and Human Services, has put a link into the chat. She, of course, says thank you for your excellent presentation, as there's multiple comments like that in the chat. But she says that the Department of Health and Human Services Administration for Community Living has worked to effectively raise awareness in communities. And she's put that into the chat. And Stephanie, if you'd like to share a little bit more about that, you're welcome to raise your hand. We'll unmute you and you can share aloud. And as she's considering that, I'll mention that Dr. Diane Barish mentions that older persons need to be open to intergenerational spaces, such as gyms, colleges, classrooms, and of course, around people around them, then need to be receptive to that and inviting of that. So,
If I
uh,
may, if I may, Janice, just briefly
yeah.
comment on that with the age-friendly universities. I think one of the great potentials of that is, currently at our university, if an older adult wants to become involved in, sort of the academic life, they might be able to go to a few lectures, or we have an Osher Institute here, but those are really kind of walled off from the rest of the campus. So particularly Osher is wonderful, but they're not going to interact with students, young, undergrads and grad students necessarily. So I think there are opportunities to, integrate older adults in the life of the university, which I think is really the first part of age-friendly universities, right? They should be part of the life of the university. These land-grant universities are really resources for everyone, and I think that's one way to really make that happen.
Well, we're very thankful that our age-friendly university initiative here at Penn State, seeking recognition. Our center is one of the leads on that, along with the Center for Healthy Aging and our OSHA Institute of Lifelong Learning. So they're partnering along with a task force across the university. So, hopefully that's going to make a difference. Donna had her hand raised, but I did just get a message from her that she's had to hop off. Is that
She did. She has,
okay?
she usually
Okay,
transitions to another
okay,
class, but we do have two other hands raised.
great.
So Stephanie did raise her hand, but we have Kathy that I will ask her question first. If you want to unmute Kathy.
Oh, I'm sorry. I didn't really, I was not technology challenged, but I must have hit something. But I'm glad I have the chance to speak because through our OSHA here at Penn State, our OLLI here at Penn State, I'm taking a class with undergraduates this semester. It's a class on adult development and aging, and it's wonderful. The instructor is wonderful. The cute thing is, though, get into class and every single student in the class opens their Chromebook and I take out my pen and paper. I like to write. I'm sorry, I didn't mean to hit the wrong button. Thank you for letting me speak. I loved it. Wonderful presentation.
Thank you so much.
Thank you, Kathy. And Stephanie. Let's see.
Oh, can you hear me?
Yes.
Yeah, thank you for letting me speak, and thank you, Dr. Farrell, for that great presentation. I just, the link I shared is to the Administration for Community Living's website, and we did a blog page in honor of Ageism Awareness Day, which was October 9th. And there are a lot of great links in there that folks can use to implement, ways to recognize this in your own communities. But I did want to just share, so not to be repetitive of everyone else, but and the College of Nursing is aware of this and participated in it. That, when I worked in Pennsylvania, we did a lot of intergenerational work pairing students with older adults. And, as the person who had firsthand experience listening to the students after they had these interactions over the course of a semester as part of their academic coursework, it was really amazing the difference it made in their perceptions. And, part of the reason for doing it was, to get people to look closer at our industry, geriatric social work. And it just worked wonders to open young people, mostly young people's eyes to the opportunities that are available to support their older counterparts within their community. So yeah, just thank you.
Thank you, Stephanie. And real quick, just to say, I think you alluded to this, there's really a workforce component to this, right? We do need this workforce to be developed. And I think anti-ageism work is a really powerful way to engage them at a, further upstream in the pipeline. So thank you.
So when you showed the chart comparing kind of attitudes or beliefs about that younger generations versus older generations, it reminded me of an activity I used to do with adolescents to introduce the concept of stereotypes. And I would first have them talk about, just describe an older adult, and you might get a few positives and you would get many negative remarks. And then I'd say, let's do that with younger people. Let's do that. How do you think older people describe you? And I just think that kind of lesson is very powerful. Do you have examples that you use with your medical students or others at all that you integrate into education?
Yeah, I mean, all kinds of examples. Actually, the one that pops into mind immediately, this is less of sort of one about sort of frailty, but I had a patient come in about a year or two ago, and he said, why are people so reluctant to get vaccinated? He pulled out his polio trial. He was a participant in the polio trials for the polio vaccine. And I guess that's an example of someone whose life experiences are so rich and can really inform a really contemporary discussion, and someone who just has the perspective. And my trainees are blown away by the life experiences that our patients have had. And I say, yeah, you know what? You could actually have a career where you're learning about all of these experiences, right? And part of that, of not being ageist, is simply asking the older adult about their experiences, because chances are they've done some really cool things that you only know about if you really ask.
Yeah. Oh, I would love to continue this conversation. Unfortunately, we're out of time, but you know, Tim, thank you so much for presenting this seminar and sharing all of this invaluable information with us and giving us the opportunity to at least explore this initially, and hopefully we can have you back again to extend this conversation. So thank you again.
That's
And thanks
wonderful.
to everyone for joining us today. It's a beautiful afternoon. Hope everyone has a great afternoon.
Thanks for having me. Take care, everyone.
Thank you.